So can we have now for the next platform of the lenticular procedure for CALEX, which is silk, a smooth approach for refractive surgery. And to take us through silk is again none other than Dr. D. Ramamurthy sir, who has been at the forefront of refractive surgeries since 1997. And he has seen the full evolution of refractive surgeries, especially has used the other platform Smile also for a long time, Clear as well, and now Silk. So it will be very interesting to know sir's opinion about Silk, how it does in his hands, and why it is better than the other technologies. Over to you, Dr. Ramamurthy sir.
Thank you, Dr. Vardhaman, for that nice introduction. Yes, I'm going to be speaking about silk, but definitely my endeavor is not to prove it to anyone that it's better than the other platforms. As he mentioned that we have been having the Visumax 500 for almost a dozen years and have a clear machine for the Zima for 3 years, using it in multiple locations, acquired the silk about 6 months back, and now ordered an 800. And I also deeply looked at ATOS. And I think the benefit we have is that, we're able to have the pick and choose what's best suited for us. And just some of you, the stalwarts have spoken, some of you might be exploring this technology. At the end of the day, if you used appropriately with proper customization, proper optimization, all of them by far give you good results. And then it's the economics and what you are able to get from the company which matters as far as the decision is concerned. So my endeavor is to cover about the aspects of silk in this particular talk. Basically, the silk is the acronym for smooth incision lenticular keratomyelitis, and it is able to give you flaps as well as the CLEX procedures, that is the lenticule based procedures. And some of the key points of this particular platform is the extremely low energy treatment through a combination of ultra short pulse duration, ultra fast pulse frequency, and extremely small focus spot size. So when you reduce the pulse duration as well as the spot size, the energy delivered per spot is extremely low. So you have to by force increase the frequency of this fast pulse delivery, and that's what exactly happens. And it is claimed that this uses about 30% less energy compared to the Visumax. But I sometimes fail to understand whether it's a combination of these factors. At the end of the day, the total energy delivered into the cornea is nearly the same, because as far as a smooth controlled dissection is needed, you need those interlamellar fibrils to be separated. And minimal tissue disruption of the tissue disruption in the stroma is what they claim. Compared to the IFS, which we still have, which we are using in one of the centers for creating a corneal flaps, which is again a good workhorse. The Elita uses much less pulse duration, just in that realm of about 100 to 200 femtoseconds. Pulse frequency is extremely high, about 10 megahertz. All along we have been talking about kilohertz. Spot size is just 1.3 microns, and all these are in the using a infrared laser. So the wavelength is nearly similar, and the spots are contiguous in this platform, and the low energy pulse creates tissue bridge disruptions, and the fact that these are almost touching each other ensures that the bridges are almost completely removed, and there is very little dissection that needs to be necessary. And this is a nice demonstration by Raghav Malik of CFS. I just borrowed this. It's just to show you the simple principle, whether it's applicable to Elita or any other platform. If you have large spots which have a significant separation between the spots, or otherwise you have small spots which are very contiguous, then obviously if you are trying to create a plane of separation, as you can see over here, this can be quite irregular. If there is a significant separation in spite of the spots being much larger. Well, if they are closely placed together and almost touching each other, then the plane of dissection seems to be more controlled. Whether it's really replicable for a lenticule removal is questionable, but this is one way of understanding how the spot separation and spot size might make a difference. And as far as the limits of correction of silk, like in any other platform, it's about minus 12 diopters of myopia or astigmatism. You could have 6 diopters of cylinder with 6 diopters of sphere, But as we all know, nowadays most of us don't do beyond 8 diopters of spherical error or beyond 2 or 3 diopters cylinder. And hyperopic model is yet to become available. And 16 seconds is the laser treatment time. And one of the important aspects is post-docking centration and cyclotorsion adjustment is possible. We are now doing it manually, but hopefully in the times to come, it might become automated and get linked to some of the abrometers that are available. And you have seen these slides quite often, but just to show you some salient feature, they re-emphasize rather, the wavelength source is essentially infrared, so all of them are quite similar. As far as the pulse repetition rate is concerned, we have gone from 500 kilohertz, 1000 kilohertz is 1 megahertz. We have gone to 10 megahertz as far as the ELITA is concerned. The Zeemer uses 20 megahertz, but it is variable depending on what is it applied for, whether it's for cataract surgery, whether it's for corneal surgery, or whether it's for channels creating in the cornea. It can be varied. But suffice it to say, the ELITA and femto LDV seems to have a very high pulse rate. And this is also goes with the fact that both of them use extremely small energy per pulse, that is 50 to 70 nanojoules. And here again it's less than 100 nanojoules. And as was emphasized by Rajesh, it's in the range of about 20 to 30 nanojoules when you're creating a lenticule. And the laser cut time is just the fastest is Visumax 800. The misnomer is 800, actually it's 2000 it should be, and it's just about 10 seconds, while the ELITA takes about 16 seconds. And the curved interface is what you have with both the Visumax as well as the AIOS. While with the femto LDV and with the ELITA you have a flat dock, because of which there is an increase in the intraocular pressure. But the advantage is that because the grip is much more significant, we have never lost suction with this particular machine, and I think that's what has been reported by the others who have used this also. Cyclotorsion compensation, manually it's available even with the Visumax 500. We have papers seen published. We have also done that, though we didn't find it very advantageous. But with the Visumax 800 and the AIOS, it's automated. And inbuilt centration system is also going to become available. And lenticular geometry, one significant difference is that in the femto LDV as well as the AIOS, you do not have a lenticle side cut, while with the others we do have a lenticle side cut. And as regards coming back to the ELITA platform, as I mentioned, it's a flat applanation, because of which you have a very strong holding, and suction loss is extremely rare. We have not even had once from the time we started using it. We must have used it in about 600 odd eyes. The intraocular pressure raise is in the range of 50 millimeters, and it's a scleral suction. That's why you get some amount of subconjunctival hemorrhages. Usually put a drop of alpha gun before starting the procedure. And the precise laser pulse delivery is extremely important for smooth removal of the lenticule. And each time the PI is docked, then there is a Z auto calibration that takes place, which compensates for the thickness and the tilt variation of the PI. And this ensures consistent treatment in each and every case. And then this has been significant work has been done by Rohit and his group as far as this biconvex lenticule, which is unique as far as this platform is concerned. All others have a plano-convex lenticule, and because of this, the distribution of the power correction is both on the anterior surface and the posterior surface. And since this is a biconvex, the number of corneal nerve fibers that are getting cut on the surface is significantly less. Hence, it's possible that the dry eye might be less compared to the other platforms. And then, since it's also the anterior lamellae are not cut, maybe it can be biomechanically more stable. But these things have to be proven over time by significant clinical as well as lab evidence. And this biconvex lenticule also is supposed to augur well for better quality of vision. This is just a short video of the procedure being done. And as you can see here, initially we started with the lowest energy setting of 40, 41. But then we have now dropped it down to 37. Actually, first time a patch was paged in our lenticule, in our ELITA platform. And there is a nomogram correction that needs to be applied. is 10%, 0.25 plus 10% of the basic refractive error. When it's minus 5 diopters, you see minus 5.75 is what is being corrected. And for the cylinder, it's just 10%. And this is the basic nomogram. Of course, as we gain more experience, we might customize it to our own needs. And this is the dog that is taking place. And it has to be, the exposure of the sclera has to be uniform all around. Then subsequent to that, you lower down the gantry. Right now, it is a two-piece docking that is done. And the company is exploring the possibility of coming up with a single-piece PI, which might make it even more user-friendly. And you keep this in the range of about 25 to 30 in the green zone. And as we dock, as you can, there is a, you can see this dot over here. This is for the centration which was done on the under the operating microscope. And this instrument does not come with an operating microscope, so you have to essentially remove the lenticule by shifting it under an operating microscope. And again, cyclotorsion control is also possible. We do it whenever there is more than 0.5 diopters of cylinder to be treated. This is the laser delivery, the posterior lenticular surface being first cut, then the anterior lenticular side cut, and then finally the axis incision. And this, because the number of times it passes over it, these incisions open very easily. And once this is done, we shift the patient under the operating microscope, and we have a table which just swings by, and this is just opening up the axis cut. And like was shown by all the other previous speakers, essentially whether it's the Zima platform or whether it's the Vizumax 500, 800 or this particular platform, once you have gained significant experience, you have optimized your energy settings, we find that the removal of the lenticule becomes easy. And just because the removal of the lenticule has been easy, that does not necessarily mean that the post-operative day visual recovery is going to be excellent. Sometimes not using excessive energy, having a little bit of resistance at the time of removal of the lenticule is a good idea, because the lesser the energy you use, at least in our hands we have found, the faster the recovery and the first day outcomes are much better when you're using optimized energy settings. That's why irrespective of the platform you use, there is some time that you need to spend as far as optimizing the energy is concerned. We have not analyzed our own results so far, and this is the first paper published by Mahipal, Rohit and the groups, and they had treated 170 eyes and in the initial cohort of studies, and what you see is a very tight control as far as the outcomes are concerned, which remained quite stable over a period of time. And there was a slight variation initially, and that's why this nomogram adjustment has also been brought about. 91% of the cases required little or no dissection is what they found, and we sort of agree with that. To summarize, the silk essentially stands for smooth incision lenticular keratomelissus, minor or no tissue adhesions because of the very small amounts of energy and extreme speed of the laser, no incidence of suction loss because of the significant intraocular pressure raise and the good dog scleral suction that you get, ease of complete lenticule removal, rarely cold spots, uncut areas, etc. If the dry spots, if there are excessive fluid or some mucus on the surface of the cornea, with any platform you could get dark spots. Planar identification is quite easy. If you want, you can have more than one axis. And then fast visual recovery, accurate refractive correction, good patient satisfaction, like all other platforms you can get with this platform too. Thank you so much.
Thank you so much, Dr. Ramamurthy sir. I think because of the want of time, we'll go to the discussion at the end. Thank you very much for your amazing deliberation about this new